Hi everybody. So as Verna said, I'm an acute oncology nurse practitioner, and I also do skin and sarcoma nurse specialist job as well at the moment. So today I'm going to talk to you about the acute oncology service that I work in, and I'm going to look at a few scenarios. So neutropenic sepsis, a patient with capecitabine-induced diarrhea. We're going to look at blood clots and TKI rashes, and then, sorry, it's another case study on Ipilimumab. So why do we have acute oncology? Simon mentioned earlier about the NC pod and them looking at cancer-related deaths within 30 days of treatment. So the National Cancer Advisory Group in 2010 felt that all hospitals with an A&E department should have an acute oncology service, and that was to improve patient safety, to reduce the number of cancer-related deaths, and also improve experience for cancer patients. So it's to join the acute medicine and the oncology disciplines with emergency medicine. So why is it important? It's important, as has already been mentioned today, because there's so many new cancer treatments coming out, and with that becomes more complications of treatment, and often these treatments can lead to life-threatening medical emergencies. So management of these patients, whatever drugs they're on, can often be quite complex, and this is partly because of concurrent treatments, if they've had pre or post surgery prior to their chemotherapy or anti-cancer drugs, and often if they've had radiotherapy before or after their treatments as well. So as I said, they're becoming more complex, and another area that acute oncology play a big part in is often we will be asked about patients' prognosis, and we're very often presented with patients we've never met before. We're seeing them for the first time, and actually it's not always appropriate for us to discuss prognosis with these patients, because we're there to help and advise on an acute situation, and then we'll need to involve the actual own oncologist that knows that patient to discuss that with them. Having said that, we do also often give advice on, we can give them an idea of prognosis, but if we will know what chemotherapy regimes are for curative intent or palliative intent, and the acute medical teams may not know that, so we can advise on that sort of thing, but generally we try and avoid doing the actual prognosis talks with patients. So our service works, there's myself and another nurse, and then we have 4 oncology consultants. Each morning, me or my colleague Mark pick up the referrals. Patients are referred via, we've got a mobile, a landline, and also via EPR, our computer system. There's a referral for acute oncology on there. So we pick up the referrals, collate as much information as we possibly can about all the patients that have been referred. So we'll look at the previous clinic letters, look up their most recent blood results, and just get as much information as we can, and then go out and see the patients, and often see their relatives as well. And then once we've done our ward round, we come back at the end of the day usually, and then make a plan for each of the patients, which we do on the ward at the time, and then at the end of the rounds we send a plan out to the oncology consultant, the relevant nurse specialists, often the palliative care team, or any other colleagues that may be involved with those patients. In May this year, we saw 74 patients with an already known cancer diagnosis, and we saw 24 new diagnoses of cancer, so it's quite high patient numbers. So now I'm just going to give you an overview on neutropenic sepsis. This is probably most of your bread and butter, so I'll go through it fairly quickly. So we know that neutropenic sepsis is when patients have a neutrophil count of less than 1. They may have bone marrow complications because of the cytotoxic therapies that we're giving them, and the neutropenic sepsis is when they have an inflammatory response to an infection, and is generally within 6 weeks, usually less, of them having chemotherapy. They're often very unwell with high temperatures or low temperatures, and we will treat them as neutropenic until proven otherwise. I'll go on to that in a minute. And another thing is that they actually may be septic without a high temperature or without a low temperature, so kind of contradicting things, but they may be septic without any temperatures, and that's because of the chemistry of their bloods and their immune system not quite working as they should, because again, because of the drugs. And then also consider if they've taken paracetamol that may be masking a temperature. So this is a lady that we saw a few weeks ago. She's a 40-year-old lady with breast cancer. She's day 8 following her 3rd cycle of Taxotere. She's on a FEC-T regime. She was admitted to A&E with a temperature of 38.2. She's shivering. She's had a neutrophil count back. We've got a machine that does it straight away in our department. Not all places do, but her neutrophils were 0.4. So what are we going to do with her? Do you want to just shout out what we should do? How? Antibiotics. So a bit louder. Blood cultures. Yeah. Anything else? Yeah, I'm hearing the right things. Good. We would make sure that the patient, this patient has antibiotics within an hour of coming into A&E. So there's national policy that says any patients with suspected neutropenic sepsis needs to be treated within an hour, because they can go downhill very, very quickly, and that can lead them, they can die from this. So that's why we wouldn't necessarily wait for their blood results to come back. If we know they're going to take an hour, 2 hours, or a day to get blood results, then we would just go ahead and treat them with antibiotics. And other tests that we may do include full blood count, Usinase, their CRP, lactate, clotting, and blood cultures from line and peripheral cultures that we will all clearly label so that the pathologists know which lumens they've come from and things. That's often a thing that we have to differentiate between where's the blood actually come from. Often they'll have a chest x-ray. Most patients coming through the doors of A&E have a chest x-ray anyway, but with these patients we want one. Close monitoring, so obviously very regular OBS, and then they may need oxygen and IV fluids. So that's you probably all knew all of that already, but it's still good to review and have a recap on these things, especially as we're moving on to talking about new drugs as well. What else with her? So we may need to consider stopping the treatment with her. We didn't need to stop the treatment. This was just a blip following her chemo. GCSF she was actually on already, but we advised her to carry that on for 5 further days. And this lady was referred to acute oncology, but by the time we'd seen her, thankfully, which is a good thing, all the things had already been done. And then all we added actually in this situation was that continue the GCSF, because that was an oncology decision rather than a medical decision, but she hadn't responded to it on the days 3 to 9 that she'd had, so we carried it on. She was referred to us, and then the oncologist is informed as well. So next we've got a 54-year-old chap who's on capecitabine and oxaliplatin. He comes in day 6 of his first cycle. He's also neutropenic. He's got grade 3 diarrhea. He has a sore mouth. What are we going to do with him? Yeah, good. Stop the capecitabine. IV fluids, yeah. Yeah, sorry, I can't hear people properly. So treat the neutropenic sepsis as with the last patient. Give IV fluids, check the Usinase, Often if they've got diarrhea, they'll be dehydrated, so we need to get on top of that quickly. Dehydration leads to renal failure, etc. So with this man, we gave 4 milligrams of loperamide straight away, and then advised him to have 2 milligrams of loperamide with each bowel motion thereafter, not taking more than 16 milligrams in 24 hours. Actually, on this slide, this isn't quite, I've not put on here that general rule of thumb is that we should wait for a negative stool sample to come back when we're giving people loperamide. And again, as acute oncology, we overruled that because his diarrhea was grade 3. He had a sore bottom. He was becoming more and more dehydrated. And again, it's often a judgment call which the medical team aren't happy to make. But with the oncology advice, we said just go ahead and give it. And because we were pretty sure it was related to the capecitabine, and it was. So we stopped the capecitabine. With him, we did add codeine, partly to help dry up the diarrhea because the loperamide wasn't working quick enough, but that also helped with his mouth, which I haven't written on here either, sorry. So, of course, he had a sore mouth, so we addressed that as well with regular soluble paracetamol, which helped him feel better with the mouth, and the neutropenic sepsis and stuff as well. So now I'm going to look at blood clots. In acute oncology, we see so many blood clots. Every week we have patients with PEs, patients with DVTs. And that's because we know that cancer patients are at 7 times higher risk of other cancer patients of developing blood clots. And some malignancies have higher risk, such as hematological malignancies, lung cancers, colorectal or other GI cancers, and also metastatic cancer. This is quite a helpful visual, I find. I don't know if any of you have heard of this. It's Virchow's Triad. So Virchow talks about and illustrates in this diagram endothelial injury, hypercoagulability, and abnormal blood flow. All of those 3 things are things that affect all of our patients with cancer. We damage their veins with the treatments that we give. They're often less mobile and have reasons chemically in their blood why their blood isn't flowing as much as it could be. And then if you've got a tumour that's going to anywhere in your body, it's going to prevent the blood flow from being as as flowing as yours or mine is. So all of those 3 things together lead to blood clots, which is why our patients are at such high risk. So again, surgery, neutropenic sepsis, and anti-cancer drugs, as I said, all affect the risk of blood clots. So the NIBs and MABs and these new drugs that we're talking about, hormone therapy and chemotherapy. So this is quite a scary slide, I think. So we know that patients are at higher risk at 0 to 3 months of being diagnosed, and then they're at higher risk up to 15 years after they're diagnosed with cancer. And we know that blood clots can lead to, it's the highest cause of death in cancer patients. So just quickly go over this slide because I'm aware of time. So we've already talked about some of this. So we also educate patients on keeping mobile to help prevent blood clots. We may use stockings if needed. Looking at quality of life issues if they've got a swollen limb because of a blood clot, and also prophylaxis and also anticoagulation. Again, especially with acute oncology, often there's a fine line of how much do we treat these blood clots. If someone's got brain mets, is the risk of them throwing off a PE greater than their brain mets bleeding, and should they be on prophylaxis? And again, that's often a judgment call that will be the oncologist's decision. And often we have local and national protocols for blood clots and prevention of them, and these protocols don't always necessarily fit in with the specific needs of cancer patients, so we have to look at them individually as well. So Just to mention tyrokinase inhibitors, I'm not going to go into too much detail about them because they've already been spoken about, but just something for us to all be aware of is that their side effects are often very subtle, and often they're not, they're not extreme enough to warrant them having an emergency admission to hospital. But it's something that we see a lot. So we know that 75% of patients on Tarceva experience skin rashes. Also, patients on TKIs can develop diarrhea, drop in white cells, poor appetite, weakness, sore eyes. And for example, a patient the other day was referred, the acute problem was that he had spinal cord compression, which was why we were contacted, but actually he was covered in a horrible florid rash, which was really itchy, really bothering him, and that was the main thing that was bothering him. So of course we sorted out the spinal cord compression, but actually we were able to advise on antihistamines, emollients, steroid cream. So there's just looking at the bigger picture a lot of the time with these side effects. Here's some nice pictures of rashes for you. So this guy's nose is very typical of a TKI rash. He's got these nasty little pustular bits you can see there, which we treat with often topical antibiotics, sometimes steroids. And again, these rashes can be really troublesome for people. So I'm now going to talk to you about Ipilimumab, which I know we've already talked about today from Simon, explaining that it's a CTLA4 inhibitor. So what it does is the CTLA4, this is in my basic version of what he was explaining, is the CTLA4 is attached to the T cells, that is a molecule attached to our T cells, and the job of T cells is to fight cancer, so in this case melanoma. So this is a 72-year-old man who I actually saw him in clinic in 2011 in my skin job. He had a diagnosis of melanoma. It's 1.1. We look at the thickness in melanoma, not particularly high risk. He, as part of his investigation, went on to have a lymph node biopsy, which was negative. Saw him in follow-up for a couple of years, every 3 months. And then in January 2013, he developed a chest wall deposit, which he had removed surgically. And because he developed this metastasis, he had a staging CT scan. The staging CT scan showed that he had a mediastinal node, a hilar node, mesenteric mass, and a lesion or lymph node in the midline of his abdomen with possible small bowel infiltration. This part of the CT was a little bit ambiguous, but we thought there was something to do with his melanoma going on there too. He was actually asymptomatic from these nodes on the scan. It was felt with him and his family and oncology that he didn't want any treatment at this point. So we gave him a few months because he wasn't having any symptoms, so he didn't have any treatment. We restaged him in May, and his scans showed slight progression in the disease. He had a family wedding to go to, so we decided to give him a few more weeks off and then start the treatment in June. So he was first given dacarbazine, which is standard chemotherapy, which we don't actually really use anymore. But at that time, we weren't allowed to give Ipilimumab until patients had had 2 cycles of dacarbazine and progressed on it. That was when we couldn't get it first line. So he had dacarbazine, which generally has very low response rates. So we restaged him in August, and actually, to our surprise, he'd had a fairly good response to the dacarbazine. So we went on to give him a couple more cycles. When we rescanned him in August, he had further slight shrinkage in all areas apart from the mesenteric mass. And then we restaged him in again, stable disease apart from the mesenteric mass. So in October, we started him on Ipilimumab. I'm just going to shorten it to Ipi. So we saw him in clinic on the 7th of November. He was doing fine. So on the 11th of November, he went on to have his second cycle of Ipi. On the 19th, I spoke to him on the 19th. no, I spoke to him, sorry, he rung me a lot, this patient. He rung me on the 20th and said that on the 19th he'd had 4 episodes of diarrhea. So I got him into clinic the next day. But the diarrhea at this point had resolved he had diarrhea on the 19th, didn't have any on the 20th or the 21st. So we saw him in clinic. He thought it was nothing. And so did we, because it had resolved at that point. So he went on to have his 3rd cycle of Ipilimumab. The Ipi was given every 3 weeks for 4 doses. So on the 23rd of November, he attended A&E, and that was because he'd had 5 episodes of diarrhea. He was sent home again. Then on the 26th, his diarrhea was persisting, his LDH was up, his urea was up, and his creatinine was low. So we started him on 60 milligrams of prednisolone. Saw him in clinic on the 3rd, and his bloods were not as good. So we advised him to take, we gave him some allopurinol and advised him to take morloperamide because he was still having the diarrhea, but the diarrhea was only sort of 2 or 3 times a day. Saw him on the 10th, things were improving. During this, actually, he didn't have his 4th cycle of Ipi. He only had his 3rd, and because of these problems, we didn't continue it. And then on the 20th of December, he had diarrhea 3 times a day still, occasionally 4. But it seemed to be improving, so it got worse, so we increased his prednisolone again. And then on the 27th, which is just after Christmas, he emailed me this picture of his arm, and he'd developed this nasty rash. I showed it to the oncologist on call, who thought it might be shingles. And then we saw him in clinic. The rash was much worse. He had spots on his other arm now, but actually his diarrhea was much better, and his potassium and creatinine were raised. So again, sent him home, and then saw him on January the 9th, and he was not looking so well, so we admitted him with diarrhea and dehydration and to start IV steroids straight away. On the 10th, he had a flexi-sig, which showed that he had severe colitis, and they took multiple biopsies when they did the sigmoidoscopy. And the 12th of January, he had a staging CT scan. The scan showed that his bowel had perforated, but he'd had almost a complete response to his treatment. But unfortunately, he continued to deteriorate. The gastro team and oncology team were involved. It was discussed with the patient and his family, and unfortunately, he ended up dying on the 15th of January, and that was from his bowel complications. So we'll never know if this patient could have been a long-term responder, but given that he'd had almost a complete response to Ipi, the chances are that he would still be here now. So there's a lot to be learnt from this, and acute oncology were involved with this patient as well, but you can see we saw him in clinic so much, and oncology saw him every week. And actually, I think that in hindsight, which is a wonderful thing, we probably could have done things differently. Should he have been sent home from A&E that day? Maybe not. Should we have got him in for IV steroids sooner than we did? Yes. But I think, again, it's really difficult because actually the diarrhea wasn't really bothering him, and it should have, I think he played it down, and that doesn't, make it okay. But I think it's because often it's fairly subtle, and then it doesn't take much for your bowel to become like tissue paper, and then you perf. So it's just I don't want to scare everyone, but the reality is that these drugs have serious consequences. And I know we've talked a lot about Ipilimumab today, but pembrolizumab and nivolumab, the side effect profiles are very similar. They're not actually as bad as with Ipi, but it's the same kind of things: rashes, diarrhea. So in summary, we know that oncology emergencies are often acute medical emergencies, and that's why early recognition and assessment and investigations of these things is vital. And early referral to acute oncology service means that the patient gets seen quickly and has a specialist review. And because there's so many new drugs coming out, we can't know all about every drug. It's not possible, and that's why we encourage patients to hold alert cards. So all these drugs do come with alert cards that the patients keep with them, and if they do come into A&E, we encourage them to, make sure that they show them to the doctors and the nurses looking after them in A&E. And these treatments are leading to more and more collaborative working, which I don't think with standard chemotherapy we've had to do as much, but with these patients we're needing endocrine advice because of their pituitary function, we're needing dermatology, we're needing gastro, and we just need to work much more closely together, use expertise from the CNSs, and education is also key, which is why we're all here today. So that's all from me. Any questions? Thank you.
Alice, thank you. That's a really good insight into
that's all right.
the work of the Acute Oncology Service. So, yeah.
Hello, good morning. It is more an inquiry more than a question. With acute oncology patient, patients would come with neutropenic sepsis in your accident and emergency. I know it's always busy. Do you have the patient group directive for the first-line antibiotics? And at the same time, my second inquiry is, how do you manage patients during out of hours and during the weekend and bank holidays?
That's a really good question, actually. So the chemotherapy question, we have chemotherapy panels. So we nationally everywhere audits their number of neutropenic sepsis patients and door-to needle. So acute oncology work closely with A&E and the cancer sister on the day unit, Kate, back there. So we all work together to try and improve the statistics to make sure that we're getting 100% door-to needle, and actually at the moment we're not doing so well with that, and it's something that we need to work towards. So we do that working kind of with everyone else. And then the out of hours, there is, so we do. And then out of hours, so patients, and we acute oncology play a part with this as well, which, sorry, I missed out of the slides, is the patients ring our oncology inpatient ward out of hours, and then they use the UCONS tool to assess the patient. So the nurse is answering the phone, use the UCONS assessment tool, which then has a flagging system of red, amber or green, and then that determines whether or not the patient's advised to come to A&E or not. So when the inpatient ward receive out of hours calls, they always let acute oncology know, and we can then look out for the patients if they have been referred in, and if they haven't been sent into A&E, then AOS or the nurse specialist contact the patient to make sure that they're okay. So there's backup there.
So for neutropenic sepsis, you've got your door-to-needle policy for antibiotics. Is anyone developing one for sort of Ipilimumab and all these new drugs for door-to-flexible?
Yeah, go Vanna.
So what's happened with the clinical trials is that we've got the drugs and they're going to market really quickly. We know that we don't have good patient-reported outcome measures, and I'm really happy to say that Becky Wiltshire, who works at the early phase clinical trial unit, has been offered her place to start a DPhil at the University of Oxford, which I'll be co-supervising, to develop some outcome reporting measures for the new cancer immunotherapies. So the answer is we don't have them yet, and we don't have the protocols yet, but we know that there's a massive and urgent need, so we are working on that. And then further to that, we're really privileged that Catherine Oakley, who's the president of the UK Oncology Nursing Society, is going to start off this afternoon talking about the position statement, and so hopefully she'll make reference to that in her position statement. So we do know there's a really urgent need for those algorithms to be in place.
And in the John Radcliffe, there's actually a specific pembrolizumab nurse specialist who's recently started. So her role is, at the moment we're using a lot of pembro in melanoma, but lung patient, more and more patients are going to be on these drugs, not just going to be melanoma. So her role will be probably partly to help with implementing kind of emergency stuff for these patients.
Alice was at a study day in Birmingham, a SAT masterclass that I was speaking at earlier in the year, and we had a number of oncologists in the audience, and there was some quite interesting discussion on how you manage patients presenting with diarrhea who have had Ipilimumab, and I think you can remember that one of the oncologists was saying, well, shouldn't we just go in with loperamide and treat as if it was cytotoxic chemotherapy? And the answer to that is no. That we need to, following the protocol that Simon was talking about, we need to be really aggressive. We need to be thinking about steroids escalating. Having sigmoidoscopy probably earlier in the treatment of the patient that Alice was talking about would have identified colitis, and that would have escalated high-dose steroids much earlier on in their cancer journey. So it is a different way of managing this patient group with their diarrhea. So I think that we really need to know that and take that message out and educate our colleagues about it.
And also the fact that it's different type of diarrhea to the diarrhea that chemotherapy, like capecitabine, the chemistry is different, and that's why stopping the drug with these immunotherapies doesn't work, because the drug is stimulating their own immune system. So that's, we need to immunosuppress them.
Would you not want to give steroids prophylactically in that treatment?
No, so you probably know the science more, but we try and make sure that patients are off steroids before starting these drugs, because we don't want their immune system to be compromised by steroids when they start out. But
so the purpose of the drug is to actually activate T cells, to stimulate T cells. So if you give an immunosuppressant, you're counteracting that. So you would aim not to have them on steroids to give the treatment in the first instance. Are there any other questions? Alice,
one more.
One more. There is one more.
Just still on the diarrhea, but going back to the capecitabine-related diarrhea. When I was doing more acute oncology previously, your capecitabine profile that you put out there was somebody that presented very early with neutropenia and with mouth ulcers. Would it be someone that you would test for DPD enzyme deficiency?
Yeah, possibly. I mean, we don't routinely test patients for it, but I think given that this was his first cycle and it was pretty bad, then we probably would. And again, that's a judgment call, isn't it?
And I think that it's about our role in educating patients and their families that it's an oral drug, but actually, especially with colorectal cancer, the toxicity is higher than we would see with infusion of 5-FU. So it is about really educating people about the severity, the high grade side effect that you can have, and that we can do something about it, but we need them to be in hospital so that we can treat them. Michael is around and about. He's doing his PhD with me at the moment, and we're working with Liz and Nicola at the AUH to do a study to optimise the outcomes of patients with oral chemotherapy. And he's just completed his health professional interviews, and what's really interesting is looking at all of those interviews. Every single health professional has talked about capecitabine-induced diarrhea and high-grade toxicities, and some patients having fatal outcomes from that. So we've got a real job in making sure that we've not alarmed our patients, but we've equipped them with the right information about how to manage it, that we can manage it, but we need to see them, assess them, and get that management in place.
Thank you.